Good morning, everyone, and welcome to our fourth webinar on our ongoing behavioral health series, where we aim to provide you with strategies and tools to help address concerns around youth mental health. We know all of you witness firsthand all the children who are struggling with sadness and hopelessness right now. We hope you leave here today with a few more tools to help you tackle these great mental health challenges. My name is Rachel Sharon, and I'm a health educator and coach with Wisconsin After School Network out of Marshfield Clinic Center for Community Health Advancement, and I'll be facilitating your webinar today. This series is made possible through a partnership with Wisconsin After School Network and the Wisconsin Department of Children and Families, and we wouldn't be here today without the support and expertise of Marshfield Clinic's behavioral health team. Before we start, I just want to remind everyone to keep your microphones on mute, and if you want to ask questions, feel free to post them in the chat and I will monitor those as they come in. It's also helpful to note that this webinar is being recorded and it will be posted to our YouTube channel within a few weeks, where you'll be able to revisit the content and hopefully invite others to join in the conversation. Our next webinar in this series will take place in January, so please keep a lookout for future messages about registration. And we'll also invite you to participate in a 5-question survey at the end, which I promise won't take very long at all, where you can give us feedback. We really appreciate that you all take the time to do that so we can keep adapting our resources to meet all of your needs. So with all the logistics aside, I'm very pleased to introduce our speakers for today, Dr. Myra West and licensed family therapist Olivia Ham. Dr. Myra West.
Thank you, Rachel.
Thanks,
All
Dr.
right.
West.
I'm so sorry. What was that?
I said, thanks, Dr. West. I will do your intro here, and then I'll turn it over so you can have the time here in just a second.
Great. Thank you.
Yeah. Dr. Myra West is a clinical psychologist and director of organizational trauma and resilience at Marshfield Clinic Health System. Dr. West specializes in traumatic stress with secondary specialization in organizational psychology, integrating the two to promote workforce psychological wellness, healing, and post-traumatic growth. Her current work includes implementation of a systemic trauma-informed care organizational model for Marshfield Clinic Health System. Dr. West has served in a variety of settings addressing trauma via trauma-focused psychotherapy, psychological assessment, training, consultation, support services, and psychological debriefing. And she's qualified as an expert in traumatic stress in civil, local, state, and federal courts. She is a very good expert to have with us today on this topic. Olivia Ham is a licensed marriage and family therapist. She enjoys working with people of all ages and specializes in reactions to severe stress and trauma, critical event response debriefing, and medical traumatic stress. Olivia has served clients in a multitude of different settings, including schools, hospitals, and clinics, homes, and diverse office-based practices, primarily working with those with trauma response and reactions. And her current work is on Dr. West's team. She's promoting workforce wellness, healing, and post-traumatic growth, along with the implementation of systemic trauma-informed care and the organizational model. Her approach is compassionate, strengths-based, and relationship-focused, and she believes everyone should have a safe and healing place to work through life's difficulties. So with that, I want to turn it over to our wonderful speakers and give them the floor.
Thanks so much, Rachel. I will share my screen and we're going to hope. Okay, and can you all see my slides or note pages?
Looks good.
Fantastic. Thank you. All right. Well, so yes, Olivia and I are here to talk about this very important topic. Olivia and I can nerd out a little bit on this topic, so that's why I was trying to preface how we would like to describe it. Obviously, it is very important for us to discuss, and you can see our objectives here, which I think were posted on the website, so we're not going to spend much time on that. But what we are going to start with are some statistics for childhood trauma. And I know you all are capable of reading, so I won't be reading this to you, but really just highlighting There are a variety of different trauma types, which we are going to touch base on. But we can see, so some of these stats are from 2019 and some are from 2020, but we can get a sense of how many children are impacted throughout our country on a daily basis with a variety of potentially traumatic experiences. I do think that this 2.5 million youth who experience homelessness, that's also a staggering stat. As well as, think about this, more than 2/3 of kids in this 2019 study reported at least one potentially traumatic event by the time they were 16. So we are going to talk about what those potentially traumatic events may include. Ages 12 to 17, 8% reported a lifetime prevalence of sexual assault. So that's by the time they were 17. 17% for physical, and 39% for witnessing violence. Many of these individuals also had more than one potentially traumatic experience. And so why is all of this important? Well, if we want to understand children's behaviors and reactions to things, including emotions, thoughts, and what happens physiologically in their bodies, we really need to assess what types of experiences have they had. And we know all of these statistics. This is based on people who are disclosing their experience of these events. So there's typically a qualifier that these numbers are likely larger than is reported here. What we want to do is help adults learn about this information so they are better able to respond to their children, kids in after school care, kids in school, teachers and staff. So really trying to advocate for more of this information to be sort of our typical language and understanding of children with these difficult events. We do want to have another disclaimer that not everyone who experiences a potentially traumatic event will develop reactions to that event. And we know that two people can experience the exact same event and one develop severe reactions while the other may be very mild, may have very mild reactions or none at all. So this diagram here gives us a little bit of a sort of progression of different types of stress that we encounter throughout our lives. This is not the be all end all. It doesn't incorporate everything, but we did want to give you some examples of all of the different types of stressors we have listed here. So putting this in perspective a little bit about what is the difference between stress, acute stress, traumatic stress, and sort of getting a sense of what do all these words mean? Are they all just stress? So I'm just going to populate some of these so you all can get some of the examples here. We include burnout and moral injury because we're thinking about the people who are working with these kids on a regular basis. And it was even in the statement on the email that we received for the Wisconsin After School Network series. So this is an important piece because it also brings recognition to how those interacting with the kids are doing, and that sometimes we may have staff who are feeling this way because of a variety of different issues, which can then impact staffing levels, retention, all of these types of things that are so important to caring for children. So just get the rest of these up here. And so then I am going to need to move my my little gallery here because it's blocking my. All right, we're just gonna get rid of that altogether. So Olivia, maybe you can help me if there are questions or anything like that that I might need to answer.
There was just one about sharing the slides.
Oh, okay. We have not shared them at this point. We will have handouts. And actually, Rachel, would you mind sharing that handout with them now? Can we put that in the chat, or how does that work?
Yeah, I can work on doing that if you're comfortable with that, Dr. West.
Yes. We've definitely made some changes since we provided the handout, because I'm usually making changes up until the time of the presentation. That's just how I roll, I guess. So here we have a variety of potentially traumatic events. Again, this is not an exhaustive list, but what we're trying to do is really describe and identify what can be considered a potentially traumatic event. And some of these are obviously categories as well. So we're not breaking them down into every specific option that we have. One of the things that is most important and essential to remember is that trauma is truthfully in the eye of the beholder. So just because we may not think that an event is a potentially traumatic event, it doesn't mean it was not traumatic to another individual. And so we really want to remember that and emphasize that. We've definitely, Olivia and I have definitely had some conversations about, you know, why do we talk about all this stuff anyway? And I'm fine. Why isn't everybody else fine? And those are great opportunities for us to talk a little bit about the trauma field and the variety of reactions and individual differences that come into play when we're trying to figure out who might have a reaction to that and who may not. So we also wanted to highlight complex traumatic stress. And so what is this? This is just us kind of continuing to provide a little more information. And so the short version is that it's when children are not able to have a consistent, safe, comfortable, and protective environment to grow up in. And so these are some of the signs that we may see in some of these children. Now, obviously, these are not exclusive to traumatic stress. There are other things that can impact this, of course. But one of the things that we really wanted to highlight is what does get impacted by someone who is experiencing complex traumatic stress. So we have these categories down here. There are 9 of them. And it sort of gives us a little bit of a view into the multitude of areas in the brain and body that are impacted or can be impacted. And I am going to turn it over to Olivia, and Olivia, I'll handle the slides. So just let me know when you'd like me to move ahead.
There was one more thing Jamie had asked: when someone experiences all those levels of stress in that pyramid, who would we refer them to for help?
What we recommend is trauma-focused treatment. Now, that also, the availability depends on where we are located. So obviously, within the Marshfield Clinic Health System, most of our locations are in rural areas. So yes, it makes it more difficult for us to identify. Yet with virtual options, which I will say, virtual is not ideal for working with kids who have complex trauma histories. So that's a little caveat, but my hope is also that perhaps we're able to have more access to individuals who are trained in trauma-focused treatments. And there are a variety. Olivia and I were talking about a lot of them as we were preparing for today. And so there, of course, TFCBT seems to be one of the most popular ones. But just off the top of our heads, we came up with anywhere from 10 to 12 without researching them, just from us having conversations. So, and actually, we did not include a slide on all of those different types of models, partly because not every model is going to work for every child. So there's a lot of factors to consider. However, if you go to one of our resources, which is nctsn.org, that's the National Child Traumatic Stress Network, there is more information there than you would probably guess. And we really love that. And even that website can take you to an NCTSN learning center where you can take additional classes to learn more about the impacts of traumatic stress and trauma. It also has a therapist finder. So it will identify different therapists that are trained in trauma treatment. Now, I'll just say right out, historically, those have been primarily in major metropolitan areas. But again, if we're now trying to take advantage of some of the virtual options, and again, you see my face cringe, but parents can also work a lot with these therapists and get suggestions of interacting with their kids and things like that that can be done virtually. So, all right.
Okay.
I'm going to turn it over to Olivia so we can try to keep an eye on time.
Yes, that's great. Okay, and I'm just going to quickly touch on epigenetics because we think it's very important and helpful to know, especially working with some of these children. So this is a very brief overview because unfortunately we don't have time to go into all the things that we would love to go into, but you can continue looking into this if it's something that interests you. So what epigenetics means is above the genome, and it refers to changes in gene expression that are not the result of changes in the DNA sequence. So as you can see from the slide, DNA does not change from birth. Epigenetics is the study of social and other environmental impacts that turn certain genes on and off. And with this, complex traumatic stress can change how our genes function, and it leads to long-term changes in all parts of our bodies and brains. And then these changes can actually be transferred down from generation to generation.
Yeah, and I'm going to jump in for 1 second because I do want to point out there are some fields and professionals that use toxic stress. Our focus, again, is on traumatic stress. So these can be used to describe very similar things. Olivia and I have debates on this all of the time, but from the trauma field, it is considered and referred to as traumatic stress. So.
Okay, so moving on to the next slide, then, as stated before, there are a lot of studies that have shown that there is a relationship between complex traumatic or toxic stress and changes in the brain structure. And then it can change how genes are expressed. And then the complex traumatic stress weakens the framework of the growing brain in these children that can lead to lifelong problems in academics, behavior, and physical and mental health. And then you can see it can also result in long-term changes and inflammation and immunity. So again, this was a very, very brief overview of what epigenetics is, but if it's something that interests you, I definitely would encourage you to look further into it. It's super, super interesting. And now we were gonna move on to the body's alarm system. So, yes, so we all have this built-in alarm system, and it's really there to help us, to help keep us safe, and it prepares us in case we need to fight, flee, or freeze. And then when children are experiencing these continued states of possible abuse or neglect or continued traumatic experiences, they can feel like their bodies feel like they're in a continuous state of alert and they're really unable to relax. So it can be this constant state of hyperarousal, and then their brain is just always hypervigilant. We had some quick things here about what parents or caregivers or teachers can do to help, and then we go further into that later. But really, if you can help them recognize in their body when they feel that trigger, it could be, you know, sweaty hands or their heart racing or something like that, that then they can help start to recognize when that alarm system is activated, especially if it is kind of continually activated, even when there's just a perceived threat. It's not an actual threat, and then help them decide if this is not an actual threat, how can we help them, you know, relax their body again using some of these techniques here. So if we move on to the next slide, it shows some response continuums. And kind of, as I said, children that have experienced abuse or neglect typically live in this like state of constant fear and danger, and that causes their brain to become hypervigilant, and then it's on that constant state of alertness, which really significantly impacts how the child thinks and acts. And a child's behavior can kind of indicate where the child is on this continuum, and that they may not be feeling safe at a particular point in time. And that can help us to inform strategies that we might use when working with the children to help them cope with this trauma response. A few fight behaviors might be crying, clenching their fists or their jaw, their nostrils flaring. They could be raising their voice in kind of an aggressive tone. And really, it can even be like feelings of anger or rage. And then some freeze behaviors might be shutting down. They might even feel cold, or they might look like they have pale skin. They could even have kind of a limp body, or they could have a sense of stiffness and heaviness. And then they could be holding their breathing, or it could just be really restricted. For all three, you know, fight, flight, or freeze reactions, the intensity of the response can really vary depending on the degree of the perceived or actual threat. So I think that was Okay, so then on the next slide, we just have some possible again, possible other reactions that you might see varied by differing ages in children showing some of these signs. I know bedwetting is typically something you might see in a preschool aged child, but it could be exacerbated by a traumatic experience. And then even into elementary, middle school, kids could continue that based on their traumatic experience. Again, it could be completely unrelated to that, but if you notice that with some of these, like hard time concentrating, nightmares, losing weight, if you notice different things in those categories together, then it might be more of a sign that this is probably a little more than typical child behavior or reactions.
Forgot to unmute. Okay, so now we're going to break some of these responses down into physiological, behavioral, cognitive, and emotional reactions. So we can see here some of these highlighted terms. Those are a lot of different reactions that are available to our children. And we term these as the physiological reactions because when that alarm system is triggered and they're kicking into perceiving a threat or some sort of fear response, these are all things that they can experience not only during the event, but even later on, if there is something like Olivia was describing that creates stress for them, some of these reactions can be triggered because their body is already used to responding to these types of things through that fear threat lens. Some cognitive reactions. Sometimes when I review some of these, I just think, well, we sort of explain away some of these things even as, well, that's not unusual. And which again, taking one by one, a lot of this can be fitting into developmental progression based on situational events. We are talking about multiple of these reactions that may trigger a thought for caregivers, teachers, parents to, okay, there's something more going on here. So trying to check that out and, reaching out for professional support, input, and further discussion about it. So some of the behavioral reactions, how many times I feel like so many of these we're talking about to the extreme here, because sometimes young children can be impulsive, right? So when we see that, we might think, well, okay, they're 2, they're 3. Yes, okay, we get that. But is it pervasive? And is it impairing their ability to function just regularly in their daily life? Also, the emotional reactions, which, I don't know, this is always a hot topic, I feel like, because Olivia and I bring up emotions and, we start to see some rolling eyes and, oh, they're just a bad kid. They just won't listen to me and all of these things. But even those emotions are telling us something about what may be going on with this child. And for all of you who are well versed in child development and what typical behavior may look like, then of course, you know what stands out or doesn't fit. And which can just then lead to more of the questioning. So an acute stress reaction, which we did have in our pyramid earlier. So we talk about acute stress, sort of in comparison to post-traumatic stress, which is why we bring this up. So acute stress can only be used, and we're not talking about diagnoses here, but it's some of the language of acute stress and PTSD that really helps us to kind of clarify and tease out different types of stress. So with acute stress occurs shortly after the event. I would even argue the same day of the event, but a lot of times people are in shock, so they don't even really know how stressed they are until they're having this very brief period of time. But after 30 days, no one can be diagnosed with an acute stress disorder. The same goes, well, the flip side goes for PTSD. In order to be diagnosed with post-traumatic stress disorder, it must be at least 30 days post-event. And the purpose for that is because our bodies respond to these types of extreme suffering in a manner that, even though awful and no one wants to feel them, that it is a process that occurs. And that is why we have these differentiations between acute stress and post-traumatic stress. We can also see that in acute stress, they're discussing dissociative symptoms, which I think is essential because sometimes we do see these right away and even before 3 days. So dissociation, which we are going to talk about, is a very brief way of describing it is when someone sort of checks out. They are feeling overwhelmed to some extent, and whether that is because of too much information or too little information. So sometimes even if someone is bored, or they're usually very hypervigilant and there's not a lot of stimulation going on around them, they can also experience dissociation. And so one of the best ways I can really describe that is that, just think of a parent calling a child who's sitting in front of the TV, maybe. There's not a lot else going on around them, and the parent's saying their name. And the child appears to be ignoring the first time. Then the parent says their name louder to get their attention. Child still doesn't respond, but on the child's end, they're starting to become aware that something else is going on besides the TV. But by the third time, the parent might be so frustrated that they are even louder or even have more frustration in their voice. And what that can sometimes do to a child who has been exposed to potentially traumatic events, that can set off their fear and threat response. So what do? What? Or something along those lines. So what we encourage when you encounter a child in this manner is to gently approach them. And depending on your role, touching is considered acceptable in certain relationships and where there's trust and all of these things. But even if, what I usually say to parents is to gently touch the child's shoulder and softly say their name, because they can become aware of the presence of the adult approaching, which they can instinctively kind of tell, all right, well, I'm in a safe space because I'm at home in the living room, or I'm at after school care and I'm doing this thing and there's nobody else really around. And so it can be a much more or much less aroused state for the child. So they are then able to respond. They don't have to be touched, like I said, but that gentle voice and gentle approach to them so that their threat or fear response does not get activated, can be hugely beneficial. So I am keeping an eye on time. So we ask about, well, what does it look like between kids, teens, and adults? So here are some of the similarities that we may see in an individual of all ages. We want to break down a little bit between adults and children because there is such a huge variance. We can sort of see what types of behaviors our kids may be expressing. And these are ways that they're trying to communicate with us, right? Because depending on their age and developmental level, they may not be able to verbalize, oh, I'm feeling so disorganized, Mom, or Mrs. Smith. And not that I'm calling out Jen at all, but just thinking of the name Smith. So there can also be a lot of discussion or even misdiagnosis with some of these other disorders you see listed down here. And again, we're not talking about diagnoses here, but it is important to realize that each one of these disorders listed below and others that we just didn't include have some overlap with trauma reactions. So it's very important to kind of figure out what is going on with an individual child or teen. And there are individuals who conduct trauma-focused assessments as well to try to tease that out. Unfortunately, Olivia and I both have experience working with kids and families, and currently we are focusing on our workforce since COVID and stress in the healthcare system. So I'm sorry to say we used to have a resource in Marshfield, but we actually have other fantastic providers in Marshfield as well, and throughout the state that you can also access through, I believe Resilient Wisconsin also has a therapist finder on their websites. So some variation.
Quick bring up,
Oh,
I had gotten kicked out, so sorry if you have already addressed this, but somebody had brought up in the chat about ADHD and the differences between that. Did you already touch on that?
I did not. I unfortunately can't see the chat, so thank you for letting me know.
Yes.
Do you want to take that, Olivia, or do you want me to?
Sure. So there is a lot of overlap in what we can see between these reactions and what a child might be showing after a traumatic experience and ADHD or the different things like that. So I think the main thing, unless you are doing the diagnosing, which I'm assuming you're not, would be you would treat it in the same way. So whether this was a child with ADHD or someone having different types of traumas, you would still kind of be doing those things, like we said, helping them recognize in their body what might be happening, and then being able to help them regulate their emotions and just kind of being that safe space for them. But even with referring, it would be someone else, trained in that would be able to then identify, is this ADHD? Is this, complex trauma? Is it PTSD? So I think really for your sake, it would still be treating it in the same way, regardless of what the technical diagnosis might be. So, sorry.
Fantastic. Thank you. And yeah, I finally got the chat open. And so I also saw a question in here about disabilities or surgeries and medical procedures. And absolutely, there is a whole nother category of medical traumatic stress. So you may have seen on the potentially traumatic events, we do have things like burns, dog bites, any type of medical procedure that individual deems as extremely stressful, extreme suffering, and potentially traumatic can absolutely result in some trauma reactions. So this is really why we're trying to share that this is a broad category, because we go back to that. It is in the eye of the beholder. So I noticed something else in the chat that I wanted to, oh, okay, about very young children who may have experienced a potentially traumatic event, and that can they block it out? And absolutely. How do we help them is a question, which I think is a fantastic question, because the way to help them is to try to address what's going on with them. You know, back in the, what was that, like 70s, 80s, and maybe even into the 90s, there were all of these, repressed memories and all of these types of things, where well-meaning mental health professionals were intending to try to help people get these memories out and process them. So now, if a child doesn't remember or recall, that's okay. If they are more, you're noticing and observing some of the reactions that we have listed on prior slides, then that is a reason to wonder. But we're never trying to find out all the specific details and all of those things, because the child's experience and perspective of it is what is most important. Again, if they are not able to verbalize anything, identifying what are the behavioral concerns, cognitive, physiological reactions, and the emotional reactions, and yes, getting into treatment, possibly having an evaluation, all of these types of things, and trying to support those children based on what is their presentation. Are there things that are really, really upsetting to them? How can you help them to perhaps, develop a plan to respond to these situations? So I'm even thinking about very young children picking out their clothes. So I'm thinking like 2 or 3 or 4, sometimes they have very strong opinions. And there are some parents who definitely say, all right, you pick it out, you wear whatever you're wearing, unless of course it's a weather issue and parents step in. But other parents are, they're just different. Everyone has a different approach. So there could be a lot of upset around choosing clothing. There could be upset about leaving the house, about coming home to the house because they'd rather be out playing at the park or wherever they were before. So really trying to address, and obviously those types of things can be very well addressed, supported, and explored with professionals who work with children and offer some of that support to parents as well. A lot of treatments strongly incorporate the parents, because even if we are child professionals, we have to be able to work with the parents and the families or grandparents, caregivers, to be able to help that child be as successful as they can be. So let's see. I am going to move ahead a bit. Ooh, excellent question. Is sexual development typically only presented in adolescents that have experienced sexual abuse? My short and sweet answer, no. Sexual development is something that occurs our entire lives. So, just think about, have you ever changed a baby's diaper? And maybe I'm biased, but those boys, I don't know. I make jokes sometimes with friends or family or whatever, that it's like automatic that their hands are just gravitating to their genital area. Well, first of all, they're pretty warm in that diaper, hopefully, and maybe they're cold. But bottom line, our anatomy, our genitalia, those are normal parts of our body. And so I won't get on my podium here, but several of you may have heard this already, but which we are starting to do more and more, using proper terminology for children's body parts. Because my standing joke is, I'm 51 and I'm still waiting for my parents to tell me the names of my genitalia, body parts, because that wasn't something that was done when I was a child. And so there are a lot of theories on if we had been, and there are some families who were doing that then too. My family, they are Southern, and my mom was the daughter of a preacher. So let me just say, there was a lot that didn't go discussed in our household. Most of my family thinks I'm nuts because I talk about this stuff all the time. But yes, it is. There is a range of typical behavior and for sexual development. We don't have any of those charts included here today. I can definitely provide some references, Rachel, if that is something the group is interested in. There's been a lot of study on sexual behaviors in young children up through adolescence, and also some guides, because we never really know, but to get a sense of what is not typical development, what are behaviors where we should have some concerns or a red flag, as I saw someone mention in the chat. So I'm definitely loving these questions as we go. And you could see, we could talk all day if we had the time, which we don't. But so really just going to start highlighting some of these things on the slides now that you all have a handout coming. But so childhood trauma does not only impact an individual during childhood. It can have an impact throughout our lifespans. That doesn't mean that it's, there's no chance for someone who's experienced trauma. There absolutely is. And what we have learned is that by utilizing evidence-based practices, we can actually sort of, I know this is not the technical term for a brain surgeon, but we see lower hippocampal volume in the brain from children who have experienced traumatic stress. The amygdala, which is our emotional brain, also can be seen to have difficulties, which speaks a lot to that emotional regulation that we are talking about so frequently in children. There are things that we can do to stimulate the brain in ways that can actually get a jump start to those brain areas and kind of connect that child through different types of therapies, practices, things parents can do at home, even in schools, and those types of things. So I know this all seems a little bit, economic stress, which, there's a lot in here. And we also look at some of the long-term health consequences. So these are all chronic diseases that individuals may experience. And there are more, there's even more on the second page, but they're specific to cortisol, the stress hormone in our bodies. And we can see very briefly, as we've done throughout this presentation, all of the different parts of the body that are impacted by severe, chronic, traumatic, complex stress. So, and this is another one that's really, shortening the lifespan by 20 years. That's shocking. So we want to get kids in to trauma-focused treatment and kind of, help start the process of them healing. So Olivia is going to talk about some of our risk and protective factors. And Olivia, I think, yeah. All right.
Yeah, I'm gonna speed through because again, you'll have these slides so you can look over them more thoroughly later. And just given the sake of time, because yes, we could talk and talk and talk. So I'm sure a lot of you have heard about ACEs or adverse childhood experiences. Just not, there's no single cause. They can take on many different forms and there are many factors that contribute. So personal traits and experiences, families, communities, and of course, you all know protecting children from neglect, abuse, and violence is essential to address each of those factors. And then as Myra had talked about some of those long-term impacts of these adverse childhood experiences, which could be, chronic heart disease, all kinds of things. So again, risk factors, you'll have all of these, but like poverty, definitely parents' unemployment, or if there is domestic violence in the family, and even just like poor parent-child relationships where a child doesn't feel comfortable talking to a parent or doesn't feel like they might understand them. So I think in the next slide, we go into individual.
Do you mind if we go to some protective factors?
Yes, that's why I'm trying to jump through these so we can at least get to the positive.
And you'll see we have breakdowns of community, family, individual risk and protective factors. And we knew there was way more information in here that we would be able to cover, but we wanted to make sure that you had access to it. So I'll be quiet.
Yeah. No, so I think the biggest protective factor would be a supportive family environment, or at least one supportive person in their life, even if it is not in their family. So even if it's a teacher or anyone that they feel like they have at least one good relationship that they can lean on somebody and somebody understands them and cares about them. And then even like household rules and having that kind of structure and balance. So it's not just a free-for-all. There's really someone there caring for them. Housing, of course, and then being able to have access to healthcare and mental health care and social services that might help them with employment needs, housing needs, those types of things.
I'm just going to jump through. And
yep. Yep.
All right.
Continuing on with the good news.
Right. Yes, this is a very important part. And so this is sort of what we were referencing earlier about these areas of the brain that are negatively impacted by exposure to stress. And I will throw out too, Olivia mentioned that this significant stress, the hormones can actually pass through generations. So there are studies that support that if, for example, let's say that there's a mom who is in an intimate partner relationship where she is experiencing violence from her partner, she is likely, she may be, not everybody, is likely to have more stress hormones than someone who isn't experiencing that much stress or violence or these types of things. And so this is what we're talking about, that then if she becomes pregnant, there is a chance that she could pass more stress hormones to her offspring than what they would typically have ahead of time. So this is why we're saying this is so important too, because while a child is in the womb, of course, they are developing and growing, and their brain is starting to grow and develop. And of course, the first 3 years are the most important in those young children's lives. But this is how we try to say, please don't give up. There are good things here. And we've done a lot of work to figure out how can we support these children and families who have had some of the exposure to these types of experiences. So there are other skills in here that people can utilize to try to help them in the event they are really struggling with extreme stress. Olivia and I know that given the circumstances, there may be some of you rolling your eyes or laughing, and we get that. Everyone's experience is different, so keep that in mind. This is a quote that Olivia knows I really love, because even though trauma causes severe stress and could actually destroy someone's self-worth, self-esteem, their relationships, all of these things, it also provides us with the power to transform and resurrect ourselves, our lives, and for us to help children do that. And one of the ways we can do that, and it's a concept, I know resilience is spoken about so much, and I really do know that. In the traumatic stress field, there are some questions about resilience. And while yes, people sometimes have an innate ability to bounce back, not everyone is capable of developing resilience skills. Not everyone is capable of experiencing post-traumatic growth. But with guidance and support, we can help children and families build skills to help them prepare for their future and for growth, development, and healing. So this is a Japanese art form where broken objects are taken and mended together with gold, silver, or platinum. So you'll see we are the hearts team, and so we had to have this heart here. So this Japanese art form is kintsugi. I've been saying this for quite a while. No one's corrected me on the pronunciation, but please feel free to if I'm saying it incorrectly. This, of course, is oh, sorry. Hopefully that's helping. The art form is that we can take things that are broken and we can actually mend them, make them whole again. And while there may be some imperfections, which every human being, we are all imperfect, but those imperfections can be celebrated as healing and growth and ultimately becoming stronger in the long term, which sometimes can be very long term. So this is why I love this mirror, because obviously it's a fragile item, but okay, so Rachel, I want to check in with you because the last slides, of course, are what people would probably really want to focus in on. Just want to check in and see if anyone has any questions or any kind of,
Yeah, so I think, Dr. West, we are out of time and I want to be respectful of everyone's time. So if anyone does need to log off, I just want to remind everyone we are recording and we'll continue to record just for these last couple slides here to get you this information. And then if you can stay on, we encourage you to do that and help us fill out our survey at the end, but I'll give the floor back to Dr. West here for the last few minutes.
Do we need to be done before you can send out the survey, Rachel?
I can try it. You go ahead and keep going through your slides and we'll work on it.
Okay. And I did see a question about not everyone can develop resiliency skills. It depends on the individual. And for some individuals, if they have experienced chronic repeated traumatic exposures. There are times, and I have encountered, and Olivia has too, some patients who have not been at that time able to develop those skills and put them into practice. They can learn the material and the information, but there may be something preventing them from implementing it. And this can happen at various points. I really believe this is something where we are strongly encouraging and trying to get children and families to the point where they are able to take a different approach to their healing. And we can do those things through therapy and other types of activities. So we really wanted to encourage parents, after school staff, teachers, any of the above. These are some things we can do for children who have been exposed to potentially traumatic events. They are safe, not minimizing what they've been through, but in that moment with you, the chances are they are likely safe in that moment. There's all sorts of other caveats we could throw into that. Making sure they know they're not responsible. We can do our best to tell them that. And frequently, I think the majority of patients I've worked with, they really don't understand that. Well, if I wouldn't have done this, if I wouldn't have done that. And so there is a lot of that self-blame. And trying to be patient, monitoring our facial expressions, our tone of voice, consistent and predictable routine. Let's see, movement. Movement is good, quiet, soothing spaces, positive affirmations. And Olivia, I know I'm going through your parts, but, and then also focusing on the fact, as Olivia said, at least one good, supportive, safe, and trustworthy caregiver is essential. So we have a couple more spaces. These are things that we've ultimately touched on throughout, but to have some trauma-informed environments, we need to have a variety of these things. So too much light can be blinding to some children. Too little light can be very scary for some children. Different noises, smells, all of these things. But trying to arrange things for comfort. And we can always ask the kids too, what they like. Is the light too bright? And I know when we're talking about a large group of kids, it can't always be something we can work out. Private spaces to have difficult conversations. Let's see. Not everything works for all kids. We've been saying that all along. Prepare them if something out of the ordinary is going to be happening, even if you don't have all the details. That, hey, sometimes, people aren't feeling well, they get sick and might not be at work, but, I don't know. That's just off the top of my head, but supporting the regulation. So getting on their level, making eye contact, monitoring, like I said, facial expressions, tone of voice, ask open-ended questions, positive body language. So just think of an adult who's standing there, tapping their foot. What did you just do? Not that any of you do this, but we try to inject humor in here a little bit. But really thinking about that and how we're approaching someone who is already distressed in some way. So making sense of their experiences through play and interactions, all of these things can be very beneficial for these kids. So that is it. Rachel, sorry, we have a ton of references at the back of the handouts. So please feel free to let us know if you're interested in more. I know it's a lot and we rushed through, but there's a lot to share.
Yeah, and thanks again for both of you being here. We gave you kind of a tall order to cover everything in a very short amount of time. But I also, to those of you still listening, I dropped the WAN email and our website in the chat as well. And those are two ways to connect with us if you need additional resources or more of this information. And then really just wanted to extend our gratitude one more time to Dr. West and Olivia Ham for being here with us today, as well as all of you. Thank you for the work that you're all doing on behalf of children and families in the state of Wisconsin. We hope you have opportunities in the coming weeks to utilize some of these strategies and share these messages, because every little bit helps. So again, if you have further questions, feel free to email us. And if you want more information about this ongoing learning series, just reach out and connect and we can point you in the right direction. Thank you for everybody that filled out the survey. And if you haven't done that, we encourage you to stay on and do that. But with that, we will wrap up, and thank you to everyone one more time for being here today.
Thanks, everyone, and thanks, Rachel and Jen.
Yes, thank you.